This is a 60-year-old male patient. This is a 60-year-old male patient. And he is a non-case of type 2 diabetes mellitus, and this is a non-case of systemic hypertension. And he is on medication for last 10 years for these comorbidities. And recently he has complaining of a rather vague central chest pain on exertion. He had never had pain at rest, and this is the ECG. So let's start commenting on the ECG. Okay. So first one, we should start with the rate of the ECG. Commenting the rate of the ECG, we can easily comment if it is a regular interval. If it is irregular interval, we cannot comment. And also lead 2 should be there for long rhythm strip to comment the ECG in irregular ECG rates in irregular ECG strips. Here we can clearly see that the intervals are quite regular. So we can see 1, 2, 3 big squares along with 2 small squares, here 3 small squares. So it is 15 plus 3 plus 2, that is 20 small squares. That is the 20 small squares. Okay, 15 plus 3 plus 2, 20 small squares in between the RR interval. So we can clearly write it as 1500 divided by 20 small squares. So it will be probably 75 beats per minute. So this is the rate of this ECG. Next we see the rhythm of the ECG. Rhythm is it regular or no? Of course we see that P wave following every QRS complex, P waves QRS complex, P wave QRS complex, P wave QRS complex. So probably this is a regular rhythm. So we can say that the rhythm is regular. Next we are discussing the axis of the ECG. You see the lead 1 is positive and lead AVF is also positive. So if AVF is positive, there can be left axis deviation if the lead 2 is negative. But lead 2 is also positive, so it is purely a normal axis. This is a normal axis ECG. ECG is a normal axis. Next comes you can check the P waves and QRS intervals and T waves. We check here. The P waves is 2 small squares and 2 small squares height. So it is a normal P wave. The P waves is normal. The P waves are normal. The P waves are normal here. Then comes the QRS complex. It's also less than 2 small squares, so it is less than 119 milliseconds. So QRS complex is also normal. We check the waves. Q waves. Any Q waves prominent over here? We check here. On the lead 2, the Q waves are deep. You see the lead 2, the Q waves are deep. You see the lead 2, the Q waves are deep. In the lead 3 also the Q waves are deep. And also in the AVF the Q waves are deep. So we should understand that what do you mean by a deep Q wave. The pathological Q waves means if it is more than 40 milliseconds wide. So pathological Q wave, what does the pathological Q wave means? A pathological Q wave means they are more than 40 milliseconds wide. 40 milliseconds means it's 1 meter. 1 millimeter. 40 milliseconds is 1 millimeter. Also, the width is more than 2 millimeter deep. That is 2 millimeter deep. That is more than 25 percentage of QRS. If it is more than 25 percentage of QRS, these are pathological Q waves. There are 2 millimeter. Each is 1 millimeter. Here it is more than 2 millimeter depth. So this is probably a pathological Q wave. Okay. You can see here on the Q waves in lead V1, V2, V5 and V6. V5 and V6, the Q waves are very small Q waves in V5 and V6. So these may be septal. Okay, these may be septal. ST segments, any changes? You check ST segment, any changes? ST segment is normal with no elevation in the leads showing Q waves. There is in Q waves you have seen the lead 2,3 AVF. In that there is no ST segment elevation seen. Okay. So you can also see the T wave. You see the T wave. There is T wave inversion in lead 2, 3 and AVF. You see T wave inversion. So we can say that 2, 3 AVF are mostly inferior leads. So we can say it is probably an inferior infarction. Inferior infarction. So clinically interpreting, the Q waves in the inferior leads together with inverted T waves point to an old inferior myocardial infarction. So the pointing here is old inferior myocardial infarction. Old inferior myocardial infarction. Because it is 2-3 AVF. So what to do with this patient? The patient seems to have had a myocardial infarction at the same point in the past, and by implication his vague chest pain may be due to angina. His coronary disease requires investigation. We need to investigate the patient. If he remains symptomatic on treatment, consider coronary angiography. If he is asymptomatic, stress MRI will allow assessment of LV function as well as determining the extent of ischemia. So this patient require aspirin and other medical treatment to optimize the risk factor. So we can do an echo also in these patients. So this is the lead Q waves in leads are probably the old infarctor, and this old infarctor is triggering angina for this patient. So we will probably do an angiography for this patient, and accordingly we can treat this patient. So thank you for listening. Have a nice day.